I greatly appreciate ROC inviting me. I would like to oppose this proposition which Anil gave. And I'm glad that 23 years ago when I'd gone for a turkey dinner, he was like a cowboy who shot me with a gun. And I thought today I would probably face him. But I was pleasantly surprised. He pleaded my case very strongly. So Anil, thank you very much. It was a good presentation supporting what I am trying to say. I think this is a myth. What is the reality? Time-buying procedure, applicable to early arthritis, better than HDO, faster rehabilitation, and uni brings back the function in the knee comparable to the normal knee. I am not really convinced. And many times I have seen patients undergoing uni might have done well with physical therapy and a brace, with weight reduction and drug therapy. That's a big possibility. And we have to find out whether they really tried that. Now here is the information from the authorities that you cannot justify as a temporizing procedure. And TK has a universal application. Mind you, a lot of people sitting in South Asian region, they have to think very seriously because type of living is very different. So uni is very patient specific and also has a long learning curve. So let us see, you all know about this, but what is most significant is when you have to do reconstruction. I think better ROM post HTO than TKR, and KS is better in post HTO TKR. You got to do, but unfortunately today we do not have that kind of training, and I predict with medial open wedge osteotomy, you can get much better results because when you preserve the bone, there is the ability to repair, regenerate, and remodel, which will never be there when you replace. Now, if you see that there is no denying of the fact there has been improvement in the designs because the failure rate from 76% went to 34%. But the fact is, if you are to do the second surgery, be prepared that it's likely to be a revision surgery and not a primary surgery. So question is better than HDO to convert future TKR? The progressively problems you said, the 27% need bone graft, 45% need tibial bone graft, 23% need metal wedges, and 10% need a tibial stem. Now technically it becomes very, very difficult for an average person, particularly you must remember that if it's a long learning curve, its right placement is very difficult. Now if we compare Baker et al. Compared to post-uni TKR versus TKR in a virgin knee, they have reported that is significantly you require a thicker poly and pain function is poorer if you do uni. So my question to you, Anil, is there a sure way we can predict ACL function and patellofemoral changes, particularly in the South Asian area where people squat, sit cross-legged and pay? Isn't it a better operation to buy time is HTO than uni because you can balance the knee and is well aligned? This is how is a lifestyle of people till they are 50, 55, 60 years. So we have to think very carefully before we accept anything. Now we know that there are so many conditions that it gives good results. Only single compartment, no lateral translation, correctable deformity, no patellofemoral arthritis, and intact ACL function. And I want to predict one more thing. We have now a lot of two-wheelers, and ladies drive those two-wheelers, and they want to stop that two-wheelers with brake and their leg. So every time they move, they are stretching their knee. So I predict that many of them will get early arthritis and will have very lax ACL. So what is the Pierce observation and has it changed over the years? INSAL in 1993 said only 6% were suitable. What was our observation? In 2007, of 350 knees, we could have 2 ideal cases from well-to-do families where we could do this, and we had defined to them that look, still there is a chance of anti-knee pain. So I think in India that's a problem. Is it applicable to large group of patients? And you see in Germany, they said only 7% were suitable for unicompartment arthritis. So this is a very good article where he made an excellent observation, which Anil also endorsed, that 250 consecutive osteoarthritic knees, only 8% were suitable TKA. But the main issue was this small percentage of suitable candidates, particularly important in light of the fact that average surgeon does less than 25 TKAs annually. And if you do only 2 or 3 annually, then naturally infrequent performance of arthroplasty may lead to more compromised results, especially in procedures that require increased technical expertise. More and more you do, better and better you become, and that's the rule. So my observation on literature research, that most papers favoring uni are from United Kingdom and propagated by UK trained surgeon, but still universally not accepted as a routine procedure as TKR. And what tells us, now this is a study from the sports medicine people, that biomechanical study of uni and bicondylar uni showed that ROM degree for uni, 123 degree for bicondylar are not better than TKR. And MIS uni had motion from 120 to 133, but knee society score was 80 and knee society function was 78. So this is an independent observation. And what is the ultimate result? Does it bring back the knee comparable to normal knee? Answer is definitely no. It is a poor functional capacity, poor quality of life, gait pattern is poorer, muscle activity is poorer. So assumption that uni preserves normal function, in my opinion, needs to be questioned. And if this happens, then God save the patient. Because this could be a big problem for a person who is going to revision. And that's what happens in many of the cases which we have seen here. And here is a 2009 article. And what does that tell us? Unicompartment knee did not differ from total knee replacement. Now where is the catch? Look on your left side. Bristol knee score, excellent 71% and TKR 53%. And look at your right about survivorship and Bristol median knee score 92 versus 88. Now this made me think that whatever is reported, is it true? And if that is so, why are they saying the observer mentioned very clearly that the decision to do TKR was done after having opened the knee? And that's why they reported better results. So friends, I personally feel that while modern trends are essential, we have to think the needs of our patients, function of our patients, their needs, and always advise an operation, which in my opinion had two-step time. So I feel any procedure should be reliable, reproducible, provide consistently good results in average hands, cover large number of population, and comparatively short learning course. So what about the uni? Friends, Anil, I feel it's a marketing gimmick. For patients who are afraid of major joint replacement surgery, you could say, oh, don't worry, it's a half joint which I do. But I know UK is not half TKA. I think there is a current trend. Uni, do it through mini. So understand, uni plus mini, complications many. Thank you very much.